I'm Michaela.
And I'm Jason.
And we're intro presenter for week 4. First off, how to become a paid member, which is not required during the virtual event, but starting next week, which is week 5, we're going to be collecting membership. So first you have to fill out the Google form, and then you make your payment to the PPS Venmo or turning your payment to Adriana at our meeting, at the end of our meeting, and then you'll be collecting your stamp card and as well as collecting your PPS t-shirt.
Okay, so for this week's topic of the week, I'm going to be talking to you a little bit about health system-based specialty pharmacy in 2020 and beyond. So a specialty pharmacy is essentially a pharmacy that produces specialized medications to treat rare or complex health problems. And this helps to improve general health systems and better patient outcomes by providing better care at lower costs. So the specialty market is currently growing, which is driven by the wider use of existing therapeutics and new to market drugs. And this market has been increasing at a rate of 8% yearly. So there are tons of specialty medications being created in the past decade, notably related to neurology, endocrinology, and there's also an increasing expansion in oncology and cardiology drugs as well. So the reason for this growth is in part due to the growth of the specialty population in the US, as there is projected to be an increase of 14 million people with chronic medical conditions within the next decade. So notably a 9% increase in Americans with chronic medical conditions, a 50% increase in cancer cases, and more than double the cases of diabetes within the next few decades. And this is all going to contribute to an increase of drug prices due to the higher demand as well. So the takeaway here is basically that over the next few decades, there will be an increasing need for these specialized medications due to the heightening demand from Americans with specialized conditions. Now, this means that there will be more and more specialized drugs being developed and also more legislation in order to limit distribution, maintain the safety criteria, and also better programs to lower the cost of health services. Now, you can feel free to tell us what your suggestions are for the pharmacy topic of the week using that barcode over there.
So we're going to recap week 3. Thank you for coming out and hope you guys all learned about the industry form of pharmacy.
Also, thank you guys so much for coming to our week 3 after social. I hope you guys enjoyed our nice game of Gartic Phone. There are a lot of nice drawings out there.
Our first upcoming event is this Saturday, the 29th. It's going to be the USC School of Pharmacy visit. It's going to be a virtual visit. It's going to be from 9 to 11 a.m. and it's going to be on Zoom. You should come out to learn more about what the USC school has to offer in terms of PharmD, and you get to interact with students and faculty, and as well as learn about the admission process. And if you're interested, you can fill out the Google form by tonight at the end of the general meeting. And if you have any questions, you can contact me.
So another upcoming event we have is the week 5 general meeting. And this will be at the same time, 6 to 7 p.m. next Wednesday. And this is going to be held in person at DBH 1300. And we're basically going to be playing some social games created by the board interns. And there's also going to be an after social. And if you have any questions, you can contact Ryan.
And then another upcoming event is another school visit, which is Western U. This is going to be Saturday, February 12th from 11 to 2. It's still decided we're still deciding if it's going to be in person or online, but it's anticipated to be in person. So similar to USC, you're going to learn more about the program. That's a typo. That should say Western instead of USC. Sorry about that. You can interact with students and faculty as well and learn more about their admission process. And if you're interested, fill out the Google form by Wednesday, February 9th at the end of that general meeting, which is week 7 or 6, sorry. And then if you have any questions, you can contact me as well.
So we also are going to be having a Jamba Juice fundraiser. So for every $10 you buy, you can enjoy an additional 6 drinks for every 1 drink purchased. And if you're interested, you can fill out the purchasing form and pay through our Venmo. And the form was also sent out on the email earlier this week.
Another fundraiser is our board fundraiser. So just if you want to support PPS, you can just Venmo us at our Venmo. And so far we have reached our $45 goal. So, and then you can check out our first challenge for the 25, which was the t-shirt challenge on TikTok. We only need $5 more for our next challenge, which is the Chubby Bunny challenge.
So our member of the week for this week is Elaine Morgan. So can we please give her a warm round of applause?
Hi, I'm Elaine. I'm a third-year pharmaceutical sciences major, and I just transferred this year from Mount San Antonio College, Community College in Walnut. Right now, I'm working at CVS as a pharmacy technician, and I wanted to work there just to get more experience working in like a retail pharmacy, and right now I'm really liking it. On my free time, I like to go thrifting or to flea markets, and I also really like trying new foods and going to coffee shops to study. So if you have any recommendations, please let me know. I also really like going to concerts, and I spend a lot of time with my dog when I'm at home. I'm also really glad that I joined PPS. Like, I've made so many new friends, and everyone here is so welcoming, and I'm learning so much more about pharmacy and like really enjoying it. So yeah, thank you.
And then we still have some of our online volunteering opportunities like Step Up Tutoring and Crisis Text Line. And pretty much for Step Up Tutoring, you can choose your own schedule. It's going to be on Zoom, and it's a great rewarding experience as you would help tutor students from low income backgrounds. And you don't need teaching experience to even volunteer. And if you're interested, you can fill out the application to become a tutor. And if you are a paid member, you can fill out the Google form by March 11th in order to receive a stamp. Similarly, for the crisis text line, it's all quarter, and it's also remote. And you're going to basically help people in crisis over text through listening and collaborating and problem solving. And then you're going to fill out the application. And then if you're also a paid member, you can fill out the Google form for a stamp as well. And if you have any questions, you can contact Zainab. You can also stay connected with us through our Facebook, TikTok, website, Instagram, and Discord.
Now, without further ado, please welcome Dr. Erin Knox, who will be talking to us about the practice of psychiatric pharmacy.
Thank you for the welcome. I'm going to go ahead and pull up my slides. All right. All right, good evening, everyone. Thank you so much for inviting me back to the Pre-Pharmacy Society meeting here at UCI. I'm really excited to tell you guys all about my journey through pharmacy, how I ended up where I am, and probably tell you a bit about where I am. So I have, just as a little tidbit of information, I have Cliff here. This is the UCI police dog in my background. So he's part of the UCI PD, and they sent out these backgrounds, and I thought he was just so cute. So I figured if this was a nice fitting kind of evening background for us to have. So anyways, back to psychiatric pharmacy. So my name is Erin Knox. I have a doctor of pharmacy degree and I'm a board certified psychiatric pharmacist. So let's talk a little bit about what that means. We're going to go through what psychiatric pharmacy is, what it encompasses, what you could do, why some people might end up choosing it, and I'll tell you a bit about how I landed where I am. So psychiatric pharmacy is pretty much defined by the two words. So it's pharmacists who practice specifically in psychiatry. What that means is we go through training to develop skills in treating patients who have mental health or psychiatric needs. It's a very unique subset of pharmacy practice because it tends to be working with a very highly stigmatized population. As you can see here, many of these disorders are used in lay press or used in between people as derogatory terms. For example, bipolar disorder or schizophrenia can be used as kind of an insult for people. And so one of the things that we do in psychiatric pharmacy is we're working against stigma. And part of that is defining these terms so that they're used correctly, making sure that the pendulum doesn't swing too far into overuse and diminishing what the definition is of some of these. So let's talk about a couple of these common psychiatric illnesses. Most people have heard of major depressive disorder, generally called depression, and that's a mood disorder similar to bipolar disorder, which is also a mood disorder, but that's characterized by more significant mood swings that can be not just depressive episodes, but also manic or hypomanic episodes. So these are two of the most common mood disorders that a psychiatric pharmacist would help treat. And then there are some of the thought disorders, such as schizophrenia. We also have a lot of psychiatric pharmacists who work closely with people who have substance use disorders, potentially also people who are dealing with eating disorders, who have had a traumatic brain injury, or some of our patients with dementia, for example, Alzheimer's disease. To put this in context, National Institute of Mental Health has estimated that in the United States, we spend $225 billion on mental health. It is something that impacts the functioning of individuals, not only in their interpersonal lives, but also with work. And it's estimated that 45 million adults will experience mental illness in any given year in the United States. So you can see there's a strong need for psychiatric pharmacists and for this specific specialty. So as far as practice goes, we'll talk a little bit about what practice might look like. But first, let's talk about where that can occur. So one of the most common places that you'll find psychiatric pharmacists practicing is in a VA, the Veterans Affairs Administration. There is a high incidence of psychiatric illness in veterans, particularly those who have been in combat. In addition, you'll see state hospitals as a common practice site. They're public, private, and academic hospitals, so notably UCI Medical Center, where I have my practice. You might find psychiatric pharmacists in outpatient mental health clinics, outpatient primary care clinics. There's been a big push to incorporate psychiatric care in primary care, because primary care, or general medicine, is the first point of contact for many people. And we screen just about everyone who comes through primary care to identify if they have any symptoms that might indicate they need some psychiatric attention. And so you'll find psychiatric pharmacists frequently practicing in outpatient primary care clinics. You can find psychiatric pharmacists in specialized care areas. I have in here eating disorder clinics, potentially pediatric or adolescent clinics, as well as prisons or correctional facilities. So what are they doing in all of these different settings? One of the main things that the staff in administration in some of the areas will like pharmacists to do is medication education. So if you guys have heard other pharmacists speak about any sort of patient care areas where they work when they have direct contact with patients, you'll hear that pharmacists are uniquely trained to provide medication education. So what you'll find is if you're doing a group, the pharmacist is going to be the one who tends to be best able to explain in patient-appropriate terms what a medication is for. Oftentimes other disciplines struggle because it's not something that they focus on. But in a PharmD curriculum, curriculum, we focus on how to teach people about their medication. We want anyone taking a medication to be educated about what it's for, how to use it, what to expect, what to do about side effects. And so pharmacists are really in a unique position to provide medication education. One of my favorite things to do for inpatient psychiatry, meaning people who are hospitalized with a severe psychiatric condition, is to provide medication education groups. And so I have developed over many years of providing med groups, various educational tools to keep people engaged with medication education. So if you think about it, you're sitting in the hospital and you are dealing with a psychiatric condition, and someone's going to come in and teach a group. And there might be 10 of you attending group, and there's a psychiatric pharmacist. You don't want to just sit and listen to someone talk about meds. You want to be involved in something engaging. And so one of the things that I had created was a crossword puzzle. And we would sit around a table and go through the crossword and talk about what the clues were. The clues were all related to psychiatric medications that patients in that unit would frequently be taking. We did word searches. We did situations where I would present a scenario and ask them what they thought about it, maybe going through true, false. I have an image that I'll show in just a moment that we put this all together in a poster to demonstrate what we were doing so people in other areas could see what kind of medication education we did. One of my favorite activities was we had the outpatient pharmacy create prescription bottles for us. And we would practice with the patients. We would give them each an empty prescription bottle, but it had a label on it with information, and it was usually for Mickey Mouse. And it would have all of the usual medication information on it that you would find on a prescription bottle. Well, what we know is some people with some psychiatric conditions may struggle with extracting relevant information from those very busy little labels. The font is small, it's like size 8 font, right? There's lots of it on there. It's hard to find some of the information. So we would teach the patients how to find the relevant information on those prescription labels. The other thing we would sometimes do, and this isn't my favorite thing, but the patients loved it, is we would fill those little bottles with candy. And we would ask them to fill pill boxes. So if someone's taking something twice a day, how many green candies would they need to take out of the bottle and put into their pill box for the day? So we would practice with that. And obviously the patients liked it because they got to eat the candy at the end. But as we'll talk about with psychiatric medications, some of them can cause significant weight gain. And so I generally didn't like to give out candy, but it was a great way of bribing people to come to the group and participate. So that's medication education groups. That's usually done in a group setting. Sometimes we would do individual medication education if a patient needed some very directed type of information. We would also provide written information to the patients. And that might include something as simple as a list of their medications and why they were taking it. Many medications can have multiple uses, and some of the patients might have struggled with remembering what everything was for. So a psychiatric pharmacist is going to be incredibly valuable for providing medication education to the patients. Depending on the setting, the psychiatric pharmacist may be involved with prescribing, including the initiation of a medication, the dose adjustments, and the monitoring, which could include lab work or monitoring the patient for side effects. And something that psychiatric pharmacists are pretty good at is managing side effects of our psychiatric medications. Also, we're really good at making sure that drug interactions are appropriately monitored. Something that I personally hold very near and dear to my heart is consultations for complex patients. So I'm a psychiatric pharmacist, but I'm also a critical care pharmacist. So I work in an ICU 24 hours a month, and I manage patients who are critically ill with things like pneumonia, who have had major heart surgeries, patients who have blood infections. These patients have really complex medical needs. And I'm very skilled, due to 18 years of doing that, I'm very skilled at managing those medical conditions. Well, putting me in a situation where I now have a psychiatrically demanding patient who has medically complex issues. The psychiatrist is not going to be a critical care physician. The psychiatrist is not a pulmonologist. They're not an internist. Their specialty is in managing the psychiatric part. But they may or may not be very well informed about some of the medical medications that the patient is taking or some of the medical conditions. And so you might have a situation where you have a patient in an ICU setting who's critically ill, but also has a psychiatric need. Well, I'm in a great position to go in and say, hey, this is going to be a safe medication. This one over here is not so safe because of the interactions with some of the other medications they're on. So I'm kind of at this great crossroads of knowing the medical part and knowing the psychiatric part and helping to manage those medications and how they interact. I have some amazing colleagues who do work with medication-assisted treatment specifically for patients who have substance use disorders. And there are many psychiatric pharmacists who also do medication administration. So one of the things that we find is long-acting injectable medications for psychiatric conditions are very common. And those require a unique set of skills for administration. Plus, they're really expensive medications. They're like $2,000 plus a single dose. So there's a lot of financial investment to making sure that the right medication is given and it's administered correctly. So oftentimes pharmacists are going to be in charge of administering these long-acting injectable medications. So here's a little bit about that poster that I talked about for the medication groups. I was able to work with, at the time, 2 pharmacy students. Dara may have spoken at one of your meetings. I feel like I saw her listed somewhere. Mary Yosef, I believe, is a 4th year. She may have started her residency. We worked together to review charts for patients that we provided medication education groups for. It's teeny tiny, but you can see that there's a crossword puzzle here, a word search, a fill in the blank, and some of the vials that we used with prescription labels to help educate our patients. So medication education groups, definitely one of my favorite activities as a psychiatric pharmacist. As far as medication management, this tends to be more clinic-based. Just for full disclosure, pharmacists are not diagnosticians. So oftentimes what this is going to look like in a clinic is you're going to have a psychiatrist who sees a patient, makes a diagnosis, might even start them on something and then say, hey, this person is complex, might need some additional assistance with adjusting the dose of their medications or making sure that they're tolerating it effectively. And the psychiatric pharmacist would be in a perfect role to actually do that medication management. Just to take a step back, somebody did comment that they said they saw Dara at OCPHA meetings. Yeah, Dara is awesome. And I think if you guys haven't had her, maybe we can take that opportunity to try and loop her back in because she was great as a student. So there's a term on here that I want to talk about because I think it's incredibly important as a pharmacist to recognize that this is one of our biggest roles. People hear about pharmacists and they think, oh, you're just going to keep throwing medications at me. You're going to always want to add medications. But one of the primary roles of the pharmacist is the judicious use of medications. And I, on a very regular basis, am more likely to recommend discontinuing a medication rather than adding a medication. We want to simplify regimens. And so you'll hear this term deprescribe. And pharmacists are in a great role to identify where there's some redundancies, where there's overlap, or where there are some therapeutic duplications. And pharmacists are going to be in a role to say, hey, we need to get rid of one of these. Let's put these 2 together and say, let's just maximize one of the medications instead of needing to use 2. This will frequently happen with some like anxiety medications as an example. Deprescribing clinics are incredibly important for the safe use of medications for all patients, but in particular in psychiatry. We also do a lot of monitoring, including for symptoms, doing rating scales to see how severe symptoms might be or how improved symptoms might be. Rating scales are also objective scales that can be used for monitoring adverse effects or side effects to medications. And pharmacists are going to be really good at making sure that we're following the appropriate guidelines for laboratory monitoring for our patients. So there's quite a bit involved with medication management. It's not something that I personally do a lot of because I'm not in a clinic. And this tends to be much more clinic-based rather than hospital-based. And so I talked a little bit about this where I deal with medically complex patients. Sometimes it's acute illness, like I said, ICU or critical care. It can also be rare diseases. So for about 10 years, I worked with the cystic fibrosis population when I was in my previous role. And that's a rare disease. It's oftentimes referred to as an orphan disease, and it has orphan medications, meaning that there's a small number of people who utilize those in the US. With cystic fibrosis, though, there's a really high incidence compared to the general population of depression and anxiety. Oftentimes there can be an overlap with some of their physical symptoms, but it provides a really unique type of population where drug interactions and drug disease interactions are important to monitor. Same can be said for transplant patients, in particular solid organ transplants. So at UCI Medical Center, we do kidney transplants, but in my previous role, I worked at a facility that did kidney, pancreas, liver, lung, and heart transplants. So multiple solid organs. And these are also some unique medications that can have unique side effects. So I was in a really special position to be able to monitor these medications and how they interact, particularly for the patients who had the psychiatric side effects or might have overlapping psychiatric conditions. All right, here's a little graphic from the Substance Abuse and Mental Health Services Administration, which is part of the Department of Health and Human Services, the US government. I'm specifically talking about medication-assisted treatment, which is essentially using a medication to decrease the use of illicit substances for people who have substance use disorders. So a common medication that would be used as MAT would be methadone for someone, for example, who has heroin use disorder. And this would be a risk reduction strategy where someone who is getting a fixed amount of this medication, methadone, would be in place of them using something less safe like heroin, which potentially has IV injection types of risks. So it's a risk reduction. It's called MAT, but the nomenclature is shifting a little bit. I do have some colleagues who work really closely with some of the Orange County agencies, and we're potentially going to be working with this organization that I'll reference later to provide some multimedia MAT support where we talk about what MAT is and why it's useful. Medication administration, we briefly talked about this. Long-acting injectable medications can be provided in a community pharmacy, which many local community pharmacies actually do. None of the hospital ones do, but some of our local community pharmacies are set up to administer these long-acting injectable medication. And when we talk about long-acting, we're talking about anywhere from 2 weeks to monthly to every 3 months. There was something that was even recently approved that's every 6 months. So these patients would receive a single injection that would last for several months, and they potentially would not need to take any oral medications. So from an adherence perspective and getting someone to make sure that they have continuous and regular exposure to their medication for management of their psychiatric condition, a long-acting injectable can be a really useful part of the arsenal in helping combat some of the symptoms that could be debilitating. This could also be provided in specialized settings like clinics, and there are even some pharmacists who go out to the patients, to the point of patients. So that might be for patients who are experiencing homelessness. They may not necessarily have transportation to get to a pharmacy or to a clinic, so they go out to the patients and they find them. And that's because patients experiencing homelessness tend to stay in areas where they're comfortable. They may be somewhat close proximity to services, but not necessarily. It can be a bit challenging, but it's really a way of making sure that the patients who need help get it. All right, so we've talked about where the pharmacists who practice psychiatric pharmacy are actually doing these services. We talked a little bit about what those are, talked a little bit about what I have done. And I talked at the beginning that I mentioned at the beginning that I'm a board certified psychiatric pharmacist. So oftentimes the people who are coming into these meetings and speaking to you guys are going to have some of these abbreviations at the end of their names. And if you see anything that starts with BC, it's board certified. And then the rest of the acronym could mean any number of things. I think there are 11 or so specialties now, mine being one of the most relevant because I'm here speaking. So BCPP, board certified psychiatric pharmacist. You might also find oncology pharmacist, infectious disease pharmacist, pediatric pharmacist. Essentially, what has to happen to get a board certification in psychiatric pharmacy? Usually you would have done a residency in psychiatric pharmacy practice. You don't necessarily have to. You could have just been currently practicing in a site where you are doing psychiatric pharmacist types of activities. It requires 100 hours of continuing education. So every year I'm doing somewhere around 20 hours or so of really specialized education supporting psychiatric pharmacy practice. So you have to stay on top of the literature. You have to stay on top of current practice. You have to renew this every 7 years. And it's always stressful when you get to the end of that cycle because you're panicking, making sure you got your 100 hours. Nobody wants to sit down and take the exam again. But sometimes you do. So it's like a 3-hour exam, super high stakes, expensive. I don't want to take an exam if I don't need to. I would much rather do 20 hours of education each year. So I am a board certified psychiatric pharmacist, so I can call myself a psychiatric pharmacist. Now, this BCPP is administered by this wonderful organization. It's the College of Psychiatric and Neurologic Pharmacists. We do have a student membership for this organization for students who are currently enrolled in PharmD programs. I'm actively involved with CPNP. I've been on their programming committee for a long time. We do an annual meeting. They do 4 days of psychiatric pharmacy didactics, small groups, and we get to network with pharmacy students who are interested in psychiatric pharmacy practice, but we also get to network and catch up with each other. So people who were my past residents who practice out of state, I get to see them every year. So I'll be in Texas in April for this conference. And there are about 1,100 people in this organization, which if you're familiar with any of the professional organizations in pharmacy, this one is tiny. Psychiatric pharmacy is a pretty small specialty, and CPNP reflects that. Just to put it in perspective, about 1/3 of the CPNP members practice in a Veterans Administration type of setting. So when I talked about VA, it's a really substantial part of psychiatric pharmacy practice. And it's rare to find a psychiatric pharmacist who didn't have some experience in a VA. So I'll talk about what mine was. I went to USC for undergrad, pre-pharmacy. I went to USC for my PharmD, and then I did my psychiatric pharmacy residency at LA County USC Hospital. So I was at USC for quite a long time. My practice or my residency practice was for the inpatient psychiatry unit at LA County Hospital. And I also spent some time at VA West LA. So I had quite extensive experience with the veterans population. I also was able to do a rotation, which was 6 weeks with Edelman Children's Hospital. So I had some experience working with children who were part of the foster care system, working closely with the psychiatrist and with the pediatrician. And I always wonder what would have happened. They were in the middle of developing a new job description while I was there, and I didn't end up taking it. They asked if I was interested in applying, but I wanted to be in a hospital setting, so I didn't end up doing it. But it was some really great work going out and doing site visits with the children who were part of the foster system who were taking psychiatric medications to ensure that their environment and their medication utilization was safe. So once I finished my psychiatric residency, I was hired at Keck Hospital of USC. And so if we just kind of go back and look here, all the way from undergrad through pharmacy school, through residency, into my first position, I was at USC. So I was, I think, at USC for 20-something years. I'm gonna have to go back and double check those numbers. I was full-time at Keck Hospital for 14 years, covering inpatient psychiatry while we had a unit, working with the psychiatry consult service, like I said, working with the Cystic Fibrosis Collaborative, teaching at the USC School of Pharmacy. I would have students and residents on rotations with me. And then my critical care part is I was working in a pulmonary ICU. I also had a wonderful experience covering an inpatient rehabilitation and physical medicine area, which was primarily for patients who had experienced traumatic brain injuries and needed extensive rehab, but also for patients who had significant medical illnesses and required physical rehab in order to regain functionality in order to go to the next level of care. So it was a really diverse patient population that I was able to work with at Keck Hospital. But after 14 years, I decided to change things up and I took a position at UCI Medical Center. And the position was as the pharmacist education specialist. So I was able to develop a practice where I rounded every day on inpatient psychiatry, developed a strong relationship with the entire psychiatric department over there, working in psychiatric emergency department, also working with the consult services. Took students and residents on rotations there. But as the education specialist, I was also doing things like staff competencies and staff training and building up the student program in anticipation of the UCI School of Pharmacy opening. So I was able to do quite a bit there as the education specialist. Led me nicely into my current role. So the UCI School of Pharmacy and Pharmaceutical Services became a school. The PharmD program was getting taken off the ground by Dean Hirsch. I was able to be part of the PharmD work group as in my prior role. So I got to meet everyone and work with everyone. And I thought these people are wonderful. I want to continue to work with them. And this position came up as the director of experiential pharmacy education. So that's my current role. That means that I oversee all of the practice experiences that students do in the PharmD program as part of their PharmD requirements. So for example, at the beginning of the year, we talked to them about getting intern licenses. At the end of their first year, they're all going to go out and do 2 rotations in 2 different settings. They're going to be at a hospital or a community pharmacy, a hospital and a community pharmacy. So they're going to spend a couple weeks in each setting. And I get to oversee the placement to ensure that we're not sending anyone where they work. For example, we're giving students a nice standardized experience in a hospital, and we're exposing them to a broad range of patient populations. As you go through the PharmD curriculum after year 1, that's the first introductory for our program. At the end of year 2, there'll be another couple opportunities for authentic pharmacy practice types of experiences. And then their 4th year is going to be all experiential. So they're going to have nothing but practice sites, 6 6-week blocks in a pharmacy setting. And so my responsibility is to develop affiliations with outside hospitals, outside organizations, community pharmacies, pharmaceutical industry, PBMs, managed care groups, and government organizations to ensure that we can have our students go out and get experiences in all of these different settings. So I'm doing preceptor development. Maybe people have never had a student before, not sure what to do. I work with them on what they could do. Here's some suggested activities. Let's make a sample calendar for you. Also get to write those syllabi and write the objectives and ensure that all of the sites are meeting the high standards that we have for our students. Now, along with this, I'm a volunteer clinical professor. So I've facilitated some small group learning for our first year PharmD students. At the end of year 2, in spring quarter of year 2, we will begin the psychiatry therapeutics, meaning these are the disease states and this is how you manage them. And in the psychiatric therapeutics, I'm going to be teaching, I'm going to be doing mental health first aid training for all of our students. It's part of the PharmD curriculum, which is a really cool certification. And I'm happy to talk about that a little bit more, maybe at the end if we have a few minutes. I'll be potentially teaching in ICU therapeutics because we don't have a lot of critical care pharmacists on our faculty yet. We're still building that up. So things like pneumonia and codes where someone's heart stops, for example. Also doing small group learning in an interdisciplinary setting. So we have our pharmacy students working with medical students. Our pharmacy students work with nursing students and population and public health. So we do lots of case-based teaching, and I'm able to facilitate small group learning and work with the students in these small groups to ensure that they're learning how to interact and speak with other disciplines and get the most out of interactions with these other disciplines. It's a really cool setup to do these small groups. So I talked a little bit about this already, what my teaching is. I do have a practice site. So I'm at UCI Medical Center, and I'm there 1 day a week with a psychiatry consultation service. So what happens is you might have a patient who is in the hospital, and the team that's managing them might be the medicine team. And they say, you know what, this patient has some really significant psychiatric symptoms that we can't manage right now. So we're going to call the psychiatry team. So they'll call the psychiatry team looks at the patient's chart. We go and we see the patient, we come up with our recommendations, and then we make these recommendations to the medical team. And so my role is to really ensure that we're paying attention, not just to the symptoms the person's experiencing, but what the potential interactions might be, and help really select the best agent for this medically ill patient. So this is where all of my critical care and medicine experience comes in quite handy. So I'm currently doing this. I hope to have some students with me in the near future. It's really great to work with the psychiatry service, because not only do I really like working with psychiatrists, but it gives me an opportunity to best utilize my skills. So it's excellent that I get to continue this practice site. All right. So as far as next steps, you've heard all these wonderful things, all of these great things that you could be doing as a psychiatric pharmacist. So if you want to know a little bit more about it, what would be the next steps? Well, if possible, try and shadow a psychiatric pharmacist. It might be a challenge because there's a sensitive nature to psychiatric patient management, but there are definitely opportunities to see what psychiatric pharmacists are doing, or just to chat. And like I said, with that organization, CPNP, we have lots of students who work with us, primarily PharmD students, but we certainly can find different things for people who have a strong interest. You can have employment as a technician or a clerk and start asking some of the questions. You know, I see that on the paperwork, this says this medication is used for schizophrenia. So what does that mean? If you have a chance to ask the pharmacist, ask them, how does this work? Well, what happens if I took this? What happens if they take too much? What happens if they miss it? Summer internships, of course, are always relevant. And, you know, there are a lot of summer internships with pharmaceutical industry. Not sure if that came up in the last session that you guys had. I think that was the recap, right? You guys had someone from industry. Pharmaceutical industry has quite a few internships that are not specific for PharmD students. So undergrad students can do pharmaceutical industry internships, and you might be able to work in a setting where that particular product line has a psychiatric focus. To put it in perspective with psychiatry, the research is not necessarily just medical research. Oftentimes, if you can get involved in research that's working with public or population health, you will often find a lot of psychiatric illness there. It's a significant public health issue, and it's something that if you work with someone who does public health research, you might actually have an opportunity to learn a little bit more about psychiatric practice. And then I have some of these organizations here listed at the bottom. So we have the Orange County Needle Exchange, which has been really supported by UCI medical students and UCI faculty. OC Mecca is this organization that I briefly introduced earlier, where it's this multi-ethnic organization that does a bit of a focus on substance use disorders and what kind of destigmatization is necessary for people to effectively get care for their substance use disorders. And then, of course, NAMI, which is the National Association for Mental Illness, which is primarily driven by family members, friends, or support groups for people who are dealing with mental illness. But they have a ton of information. They have support groups. They have Ask a Pharmacist on their page. There is the Orange County NAMI chapter that does a lot of fundraising, and they do free events in the evening. They do educational events. So NAMI.org, or you can look up OC NAMI if you really want to be involved. And those would be organizations that would be great to volunteer with if you're looking for some kind of overlap into psychiatric pharmacy. All right, and before I open it up to questions, I am going to talk about one thing that I realized I did not include in my slides, and that is the why. So I mentioned lots about how prevalent psychiatric illness is and how much money we spend on it. Now, obviously there's a need, but me personally, why did I pick psychiatry? So going way back into undergrad, I thought I wanted to do research. And then I spent some time in a research lab and I realized that was not for me. I love interacting with people. But I also have a little bit of an adrenaline junkie kind of side where I like high acuity. And that's why I liked critical care. So I was trying to figure out where this overlap was. How can I effectively do something where I get to talk to people, but also do critical care? So one of the things you'll find is if you spend any time in the ICU, you don't really get to talk to your patients. There's some have lots of tubes in, they're on ventilators, they can't talk. I love talking to my patients. So how am I going to do critical care and still talk to my patients? So I realized inpatient or hospital psychiatry was really a great fit for me because these patients were really acutely ill. They needed hospitalization. So it satisfied that kind of critical need, but they are psychiatry patients and you cannot treat a chart with psychiatry. You can't just read about the patient and be able to effectively treat them. You have to sit and talk to them. And that's very different than something like infectious disease. With infectious disease patient care, you're often going to look at laboratory values. You're going to look at the culture to see what's growing and what the sensitivities are. You might look at their kidney function, some of the other medications they're on. But you don't need to talk to your patient. You can very effectively treat hospitalized patients for their infectious diseases without talking to them. You can't do that in psychiatry. You have to talk to the patient. What's their story? What are they feeling? What's the most distressing symptom to them right now? When you take this medication, how does it make you feel? What is the barrier to you picking up this medication? You told me you couldn't go get there. What was stopping you from getting it? And these are the sorts of things that you have to talk to the patient to get. You're not going to get from a lab. You're not going to get from just a chart. You have to go in and talk to them. And so that's why I have always liked psychiatry, because I love stories. I think I'm like an anthropologist at heart. I love stories. I love to talk to people and hear their stories and how they ended up where they did and what's going on with them right now. And I love to hear that. And so for me, psychiatry was a natural fit. Hospital psychiatry ended up being a natural fit. Same with consult psychiatry because it's overlapping into some of my other skills with critical care and my need for high acuity management. So I wanted to make sure that I threw that in. Certainly, if I have another opportunity, I'm going to have to put in a why for psychiatry for me. But that's for me personally. I didn't have any other reason other than I liked talking to my patients. So with all that being said, I think I'm right on time, right? 6:50? I think it's perfect. We get
Yes,
to,
you are. Yeah.
Awesome. Let's take some questions.
If anyone have any questions, you can go ahead
If
and
I
ask.
may
Dr. Brown.
ask,
Yeah,
or
go ahead. Oh,
yeah. So you talked about why you really love psychiatric pharmacy. Are there any challenges that come along with it, like that you
Yeah.
face in your day-to-day?
Absolutely. So there are some significant challenges, Dylan. Thank you for this great question. Psychiatry is not always reimbursed at the same rate as other conditions. And so what we found, and there is a lot of political and financial reasons over decades to how we ended up where we are with psychiatric care. But psychiatric hospitals struggle financially. And so it's difficult to get adequate reimbursement. So oftentimes that means that only the bare minimum is going to be paid for. So it can be difficult to find a role that is lucrative enough financially to support someone doing a full practice. And that applies for anyone working in psychiatry. Comparing it to something like orthopedics, which tends to reimburse very well, psychiatry does not reimburse well. In addition, the stigma associated with psychiatric management can be very profound. There's certainly been a bit of a shift away from this fear of talking about psychiatric illness, but there's also a concern that it maybe shifts too far, where there's a bit of a dilution for some of these terms, where someone says, oh yeah, I was depressed last year. I just started sleeping better and eating better and I was fine. Okay, so having depressive symptoms is very different than someone who might be dealing with a major depressive disorder where they can't even get to the point of getting themselves up and getting dressed and going to work. And so there's a bit of a challenge in striking a balance between being stigmatized and being so destigmatized that it loses its value and its impact, because these are still some serious conditions that need appropriate management. And then getting the financial reimbursement for those can certainly be challenging. There have been lots of inpatient psychiatry units that have had to close because of financial reasons. So great question, Dylan. Tracy, got your hand up?
Yeah, I was actually going to ask a similar question, but also like, how does it like impact you like personally? As like for me personally, like I've definitely thought about that career so many times, but I'm also super afraid that it would affect me as well. So
you're talking about how the financial part affects you.
just like talking to patients or just like hearing their story, and then does that affect you?
Okay. So there are certainly times where it can be challenging because you hear very sensitive information, and it can be a bit disheartening to hear about the struggles that some of your patients may experience just in something as simple as finding housing. So there are certainly challenges, and it can be very frustrating. And I put it in perspective, much like I do with critical care. So with critical care, there is this element that some people say, well, I can't do it because I can't handle people dying. But much like psychiatry, you know that these people need assistance and you do what you can, and someone needs to do it. So I am comfortable in this role. I am not comfortable in dealing with something like pediatric oncology. To me, that's not something that I'm comfortable doing, that I've been able to manage with my experience. I just know that, pediatric critical care is not for me. That's the thing that I bring home and I cry. But with critical care for adults, I can look at it and say, we did everything we could. Really, I fought for this patient. We gave them the most appropriate antibiotics, and sometimes that's all you can do is just provide the support that's needed. Similar with psychiatry, I can't change this entire system, but I can make sure that for my part with this medication, this person knows what they're taking. They're not taking anything unnecessary. We've made this as simple as possible for them. I've given them all of the tools that I possibly can. We've set them up with appropriate outpatient care. And we just hope that our colleagues are able to continue on and provide the appropriate level of intervention needed to ensure that our patient doesn't come back to us in the hospital. So it can certainly be challenging.
Thank you for that thorough response. I had one other question too. You mentioned earlier that you were also working with like CF patients as well. If someone was interested in like pulmonary, like that kind of field, and they were interested in psych, like the complex patients you were talking about, would you suggest that you get a residency in like pulmonary or in psychiatry? Or
yeah. So I would say that I am part of the very, very small group that is experienced in working with cystic fibrosis patients and ICU patients and psychiatry. There are not a lot of us. Honestly, there's probably just a couple dozen that I know of through the organization from the psychiatry perspective. So I think it really depends on what your ideal day-to-day looks like. For some people, they can have an extensive experience in psychiatry, but they took the route of doing a critical care residency, and that's really the heart of what they like to do. For me, the heart of what I like to do really is psychiatry. That's where I get excited. So early on in my career, I realized, and actually this was when I was in my PharmD, I realized that the best way for me to figure out what I wanted to do was to just start talking about it and then really listen to myself. And I listened and I was like, you know what? I am super excited when I talk about psychiatry. I'm meh on everything else. Like I can kind of get myself excited. At the time, I was really excited about women's health. I worked at the main campus pharmacy on the USC campus. And so I did a ton of emergency contraception and birth control. And I really liked working with young women and doing women's health. I got excited about that, but I was like, I don't know if I can see myself doing that long term. So I just started talking about the things, finding out what got the most passion out of me. I'm obviously pretty expressive. I use my hands a lot, I'm kind of loud. And so when my voice goes up even more, I get even louder. I knew that I was excited, and that really was with psychiatry. So I realized that was my passion. So I try to make it work. I can't say that there's one path. One thing that I've learned over the years is there are multiple paths that can lead you to the same position. And one single path can lead you to lots of different positions. So there are so many different ways of getting from point A to point B and everything in between. There's no one formula.
Thank you so much.
And I'm sorry, that's not like a great, I can't give you a recipe.
No, that
but
was perfect.
I look back at some of the critical care pharmacists that I work with, and I sit around and I'm like, okay, this person did a residency in pharmacy practice, then they did a second year in cardiology. I did a psychiatric residency. That person did an ambulatory residency. And all three of us are working in the exact same types of positions. So 3 very different paths to get to the same job. And then I look at all the people who have done psychiatric residencies and how diverse our current employment is. So you can end up in lots of different types of positions. So there's no like one simple, do A, B, C, and you'll get to point D. Great questions, Tracy, thanks. Anything else?
I have one quick question. So since you, I think you talked about a lot, psychiatric pharmacy is certainly, not as not so much people are currently specializing.
Mm-hmm.
Do you think it's certainly a growing field in response to the current demands for awareness about of mental health and mental illnesses?
Yeah, so I think there's been some really interesting trends with the need. One of the things that we found in the early 2000s was with the new antidepressants that came out, many primary care physicians started to feel much more comfortable managing depression in a primary care type of setting. But now we don't have 3 medications to select from. We've got over a dozen. And so it's become much more complex. And there's been a bit of awareness that, hey, as a primary care provider, I need to screen for this, but I don't know if I necessarily feel equipped to continue to manage this. And so there's this awareness that although they may start managing, they may not be in the best position to continue to manage or to manage someone who is not responding or decompensates. Now, putting that in perspective with the lack of psychiatric care available, psychiatrists are in super short supply. And so when you look at psychiatric pharmacists, psychiatric nurse practitioners, or PAs, there's a huge role to expand the footprint of psychiatry. And pharmacists, being so good at managing medications, would be excellent resources in those primary care clinics, which is why you find so many psychiatric pharmacists working with internists. It's a really common practice site, particularly for faculty. It lends itself very well for faculty practice sites, and faculty are usually really good at those types of roles.
Thank you. And yeah, I'm sure actually like a lot of people here after listening to your great presentation will be interested in this field as well. So I think that's all the time we have for today. Can I get another round of applause for Dr. Knox? Yay. Virtual clapping. Hopefully this is the last time, and then we'll see each other in person next general meeting. So again, once again, thank you, Dr. Knox, for joining us today. This will conclude our general meeting today. And our next meeting will hopefully be back in person, as we will be hosting our intern social at DBH 1300, and see you guys there.